Hello and welcome to the CKD Symposium for Primary Care Providers. My name's Heather Johnson. I'm the Director of Programs for the Kidney Foundation of Canada, the BC branch. And in partnership with BC Renal Agency, this is our second year putting on a CKD Symposium. So welcome. We have a number of people here in person at the WASC Centre in Vancouver and quite a number live streaming. Please let us know if you have questions. We can take questions from the floor and from people remotely. Do I need any instruction around that? And if you do have questions remotely, just type in your name as well as your question. The Kidney Foundation is committed to supporting kidney patients throughout the country. In fact, the Kidney Foundation's been around for 50 years. This is our anniversary year. And one of the ways we like to support patients is by trying to ensure they have as much information as possible to be able to make informed choices about their kidney health. And this is one of the steps that we take. If we can inform primary care providers of all the cutting-edge renal information coming out, that's a really good step. So we have a lot of incredible medical professionals speaking here today, and I'd like to introduce one of the chairs of this meeting, and that's Dr. Monica Beaulieu.
So just before we get started, I'm Monica Beaulieu. I'm one of the clinical nephrologists that practice out of St. Paul's. I think we co-manage a lot of patients together. And I'm chairing this event with Dr. John Pawlovich, one of our family practitioners that has a very long history and interest in CKD care. I have a few housekeeping things before we get going, but I do want to try, since we have such a small group, even though the room is a bit daunting, I'd like to make this as interactive as possible. We have a group of 8 to 10 nephrologists from BC here just to answer your questions. So hopefully even during the talks, if you have questions, please just put up your hand, use your microphone so the people online can hear. And we're happy to kind of stall along the way and not wait for the end. And we'll use the Ask an Expert section right through. A bit of housekeeping. The CME credits will be mailed to you after the event. The PowerPoint presentations will be up on the BC Renal Agency website as well as the video stream. And there'll be an online evaluation survey as well, which is quite important. We use the results of the survey from last year to help form the content of this year's presentation. And so I think without further ado, John, do you want to come up and anything you want to say?
Hi there. We just want to welcome some of our invisible guests today. So we're streaming this event to across the province. There are about 30 plus people who are streaming it. So imagine, if you will, those people in the room today, and maybe it'll make us all feel a bit more included. And so I'm grateful for the opportunity to be here today to kind of give people a primary care perspective on CKD and help remind my nephrology colleagues here about the fact that as primary care providers, we think holistically and we have to think beyond kidneys and how it really interrelates with all the other challenges we have with chronic kidney disease. So we're going to go through some slides here and just kind of set the stage for you. We have some wonderful speakers who are going to touch on more specifically some of the key areas of kidney disease that we see in primary care. And again, we really want to encourage everyone to stop and ask questions as we go forward so that you feel you can ask in the moment things that are on your mind. Okay, thanks.
All right. So in the true interest of shared care and communication, John and I are actually going to tag team this presentation. So we're going to go back and forth with slides, areas where we think our focus lies. So I just wanted to start about 20-25 minutes talking about what is renal disease in Canada. What is the challenge? How many people do we have? What does it mean to them? So we're going to go through 4 objectives. We're going to try to give you an appreciation of the prevalence of kidney disease in Canada and what type of kidney disease that is. I'm going to talk a little sobering about the impact of kidney disease, especially end-stage kidney disease, on patients' lives. We're going to go through the guidelines, hopefully in very succinct point form, and learn some caveats with respect to diagnosing patients. You are the Ministry of Health actually had the new updated CKD provincial guidelines come out tomorrow to coincide with this lecture because they knew that we were talking today. So we were the first ones to kind of go through the new revised guidelines, which you'll be lucky or fortunate to note aren't much different. And we're going to have a little quiz at the end. So we have about 35 million people in Canada. The estimates when you read the news is that 1 in 10 people have CKD. And that CKD, so that's about 3.5 million Canadians have some form of CKD. Most of that is early stage chronic kidney disease or abnormalities in the urine like proteinuria. There really are about only 40,000 people in Canada living with a kidney transplant or on dialysis. So even though when we hear about nephrology, we think automatically to dialysis or transplant, only about 1% of the patients with CKD in Canada are actually end-stage kidney disease. And so we're going to try through the course of the morning to help you tease out who those people are that are likely to progress. And we're going to have 3 themes as we go through each of the talks. It's really going to depend whether someone's going to progress depends on how old they are. Younger actually is against you in this respect. So young patients with, of course, lower GFRs and a lot of protein. And that's going to be a recurring theme. Consider the cause of the kidney disease, the age of the patient, what their GFR is, and how much protein they have. Patients on dialysis do unfortunately suffer quite a bit of mortality and loss of quality of life, and I'll give you a few numbers. And by identifying CKD earlier, and mainly identifying the people that we think are going to progress, we can help delay that progression and initiate treatment in a timely manner, and we'll show you some literature that actually does improve mortality. So this is the basic stage 1 to 5 of kidney disease. And what it shows you is that most disease is in the earlier stages. So these are extrapolated to Canada, about the approximate numbers in each stage. And stage 4 and 5, really the minority of patients. I just want to remind you that the semantics are a little bit unfortunate because to have kidney disease based on GFR alone starts at stage 3, right? So if you have nothing else wrong with you and just a low GFR, and a GFR below 60, you're automatically stage 3, although that's really the first stage of your low GFR kidney disease. So GFRs above 60, 60 to 89, above 90 are normal. The only way you get into that stage 1 or 2 kidney disease box is if you have something either structurally or functionally wrong with your kidneys. So you have IgA with a bit of blood and protein, but normal kidney function. If you have polycystic kidney disease, but normal kidney function. If you have a transplant and only have 1 kidney or a solitary kidney, that puts you in the CKD stage 1 or 2, but your GFR is actually in the normal range. And that's important for patients when they start Googling that they have stage 3 disease. They think they've passed stage 1 and 2 already, right? But you remind them that stage 3 disease, unfortunately, it's the naming, but it's the mildest form of kidney disease. This is just to give you an idea in your health authority, and I'm not sure where everyone is from, but how many patients we follow in the kidney world. So we have about 12,000 patients that we follow for CKD not on dialysis. There are only 2,000 patients getting hemodialysis in center in BC. There are 150 people doing their dialysis at home, so the blood dialysis machine that they actually control everything in their own home. About 800 on peritoneal dialysis for a total of about 15,000. So the majority of patients that actually we follow too are CKD patients, usually in the GFR 30 or less. So now for the sobering. So patients who reach end-stage kidney disease have a life expectancy worse than most cancers, even if they start dialysis. The average life expectancy, even if someone has good dialysis, about 5 years. And if you start someone over 75 on dialysis, the average life expectancy is 2 years. Now, we all have patients that we've told this to, and now they're celebrating, we're bringing in the cake for the 100th birthday because they started at 92, so there's always exceptions to every rule. But it's important for us when we talk to our patients to make sure that people know what they're getting in for with end-stage kidney disease. Dialysis is not a cure. It's a palliative therapy for a lot of people that when you're older doesn't often keep you alive more than if you had comprehensive conservative management. For young people, that loss of life is even higher. The average life expectancy of someone who starts dialysis in their late 20s is about 20 years. And if you have a transplant and you're 30, you get an extra 20 years of life than if you didn't with dialysis alone. And I just wanted to give you a little, one slide on the flavor of transplant. What's a list? What does it mean? What's current state? So if you're pre-dialysis, there's no list. You can't get any on any list for a transplant. So late-stage CKD, the only way you can get a transplant before dialysis starts is if you have a live donor. And in BC, we're fortunate because we do the most proportion of live donors anywhere in Canada, far and away. These don't have to be a family member, a friend, an acquaintance, a co-worker, an altruistic donor. If you do not have a potential donor, your time on the wait list starts when you start dialysis. And right now, we have a huge discrepancy based on blood type, and it's quite amazing. So if someone's blood type B, they're waiting about 9 years, versus an A that it's about 24 months, to almost the point we're looking for A donors to try to get them on the list when we have an A kidney. So knowing your patient's blood type actually does help us in some of our discussions with them about their future. And once you get a kidney, about half are working at about 15 years. So most patients with CKD don't die of CKD, right? The vast majority die of other things. And the reason for that is having a low GFR is bad. This is your adjusted rate of death, and this is your GFR. And as your GFR goes down, your adjusted rate of death goes up. And that's not really a renal death from end-stage kidney disease. That's mainly from cardiovascular disease. These patients are also, it's like a super cardiovascular risk factor. It's a risk factor for infections, so immunizations for these patients with CKD. It's a risk factor for transient acute kidney injury blips, like little heart attacks of the kidney. It's cognitive impairment goes with kidney disease, and interactions with drugs. And so the patient with kidney disease is 5 to 10 times more likely to die from a cardiovascular cause than ever to reach end-stage kidney disease. So a lot of what you guys do in practice is risk factor modification, and the treatment of kidney disease is really risk factor modification for their heart disease and their diabetes. So just as I finish this part, there have been studies asking primary care, and we've surveyed primary care saying, what are you comfortable with and what might you need a little bit more support or help with? And you're all more comfortable than we are treating hypertension, no problem. In the setting of CKD or in the setting of CKD and diabetes, maybe a little less. But identifying proteinuria and using proteinuria results to manage CKD, a little bit less. So hopefully that's the flavor of the audience as well, and we'll go through some of those answers. So just as we transition over, I'd like to put these patients, because these are all, patients that we see every day. So all of these people, the 86-year-old woman, the 72-year-old man, and the 48-year-old man, have the same GFR, right? They're all in the same stage. They all have a GFR of 30. The first woman has a urine ACR that's normal, so anything under 3 is normal. The second is some proteinuria, and the third is someone with type 2 diabetes who has a lot of proteinuria. And so even though they all have the same GFR, their risk of progression hugely different. We have a lot of progression equations. That 86-year-old woman with a GFR of 30 is going to be okay. We might counsel her to reduce risk factors of acute kidney injury, which Dr. Farrell will talk to you about, but look at her risk of needing dialysis. It's minimal. Versus the guy on the other side at the extreme, he's actually destined, if he doesn't die from a coronary event or something first, to reach end-stage kidney disease. So even when his GFR was normal, if you saw him that much protein, he's someone you'd want referred in very early. And we'd manage him in our CKD clinics even if his GFR was 70, because we know where he's headed. Hopefully we can help that. So with that, we'll go through the guidelines, and hopefully this will give you a flavor of why the guidelines were laid out the way they have been. So I'll pass it over to John to talk a bit about who to test for CKD.
Thanks, Monica. Just a reminder to everybody, Monica did a really nice job at setting the stage to explain chronic kidney disease and the numbers. You can see, we sometimes get lulled into the feeling that this is a nephrology-specific entity, and like most, if not all, chronic disease, it's really a primary care issue. And we, as primary care providers, deal with the 98 to 99% of the people who aren't on dialysis and aren't in a transplant situation. And that's not unlike heart failure and hypertension and diabetes and all the other chronic diseases. So being mindful of the fact that primary care providers are really the most integral part of this whole management strategy for chronic kidney disease is really, really, really important. And sometimes CKD gets left behind in terms of the identification of what the problem list are people who have their various chronic diseases. What I mean by that is we often will list coronary artery disease and diabetes and hypertension and so forth. Sometimes we forget to itemize that chronic kidney disease is on the problem list, and flagging that is really important, especially in an electronic medical record, for the reasons that Monica alluded to, by being mindful of certain drugs interact, certain drugs are nephrotoxic, and throughout the course of a year, a patient is going to be challenged with different illnesses, GI illnesses and so forth, and trying to prevent acute kidney injury on the top of chronic kidney disease is really something that we can have an impact on. So I'm just reminding everybody that primary care providers are really where the vast majority of management is going to be, and formalizing in your charts, identifying chronic kidney disease that's there will help ensure that the patient not only gets managed properly, but prevents them from perhaps getting things that are deleterious to their health. So who do we test? Who's at risk? So we have patients, obviously, in primary care who come and go, and some are already come to us with the diagnosis and some don't. Everyone in the room here practices primary care, I take it? Yes? We have some residents here. So there are no secrets. The usual suspects that we want to be mindful of: people with hypertension, people with diabetes, people with a family history. Our ears perk up when we hear this. People with vascular disease, and specific ethnic groups. So Indigenous people, so First Nations people that I work with in northern British Columbia are at a real risk for kidney disease. When I went to Australia to do some work with Indigenous people, their risk is shockingly high. And one of the communities we went to, the life expectancy is 52 years of age, because everyone is dying of the complications of chronic kidney disease. So Aboriginal people, people from the South Pacific, islanders in the South Pacific, people of African descent and Asian descent. These are broad categories, but people you should be thinking about as at risk for chronic kidney disease. So you identify this person, you think, okay, they're potentially at risk. What are the tests that we're gonna order? And what's new in the latest iteration of the guidelines is really the addition of the ACR, the albumin-creatinine ratio. In other words, measuring protein in the urine. And historically, if we rewind the clock a few years back, it's kind of a unidimensional diagnosis using a GFR, a creatinine. So creatinines are done, and in British Columbia, the labs automatically calculate a estimated GFR. And don't ask me, the formulas are I've been to some of these discussion and rounds with these people who are a lot brighter than I am, and we don't want to enter into that discussion today, but just be aware that it is an estimated GFR. It's a calculated thing, and but what we've now moved past the GFR being the sole measurement of kidney function, and now we look at protein in the urine. And the other important part I'll point out is we've now moved past the microalbuminuria. So that kind of terminology is kind of gone away with. When I remember learning this for the first time, I thought microalbuminuria meant really small micro protein particles in the urine, and people had all sorts of different ideas about what microalbuminuria meant to them. In other words, don't think of it as microalbuminuria anymore. Think of it as albuminuria and the new stages of how we measure it. I'm a big fan of keeping things simple, and so the residents who come along with me to learn some of this stuff, they know that I try to really emphasize the simplicity of management so that we tend not to forget the big things. So if you think of screening now in two dimensions, one is a GFR and the other one's an albumin-creatinine ratio. And if you think of you already have seen on the chart how GFR, and you remind yourself of the stages and the different cutoff points. And ACR, if you can keep it simple too, just think of 0 to 3, 3 to 30, and 30 and above. And low, medium, high risk, if you keep it like that, you'll be in good shape. So Monica alluded to a normal GFR being over 60, notwithstanding there can be other issues in the urine or with the structure of the urinary system. When we think of GFR, remember we want to always think of measuring GFR in a steady state. So when people are acutely ill, when there's a change in something, that's not the time to really pin your emphasis on a particular number. And when in doubt, repeat the test is really because it's a trend that we want to establish as opposed to one specific number. And likewise with the albumin-creatinine ratio, again, one of anything may be not indicative of what the true state of affairs is. So you want to repeat things over time. Normally a GFR within a couple months be reasonable, and if it's sustained, someone has a sustained GFR in the 40s, then it probably is. Likewise with the albumin-creatinine ratio, you need to repeat it because there are certain things that will affect protein in the urine that you want to be mindful of, and you want to make sure that this is a sustained change for them. So people have a GFR of greater than 60, their ACR is less than 3, they're still at risk, so when should we recheck it? A year or two. Keep an eye on it, okay? What if their GFR is less than 60 or their ACR is more than 3 or both of those are abnormal? Well, then the patient has chronic kidney disease, and then our job is to sort out the etiology and make sure they're managed appropriately.
So one caveat is that the GFR equation was never meant to test your GFR above 60. So it was actually only calibrated to 60 and below. So we often get this situation where you have a patient whose GFR and you're monitoring every couple of years and it falls. It falls from 89 to 72 to 65. You do a urinalysis. And I guess the other caveat with that ACR and GFR is at least once do a urinalysis, because especially before you refer, because we need to know if there's red cells in the urine at least first for diagnosis. But so you do a urinalysis, it's fine, ACR is normal. So this person's GFR has fallen. Would you refer him because it's fallen almost 20 points, or would you just follow him? And this one, since we talked about it, this a GFR isn't falling when it's in the normal range. Now, there's always caveats for that, but then this person actually was a consult, and then I did a repeat, and it was 92, right, before we even saw. So we just called and said, actually, I don't think they have to be seen. Do you have any other concerns that you want me to see the patient for? And the reason for that is because it used to be some variation in BC, but we're really lucky in BC. The renal agency pays to standardize all of the creatinine measurement tests in BC, and many other programs don't do that. So it used to be if you went to this lab, they'd give you this GFR, and this lab would give you this GFR. And in BC, we actually recalibrate every year the creatinine. So wherever you go, it should be the same number. But at the higher ranges, there's a lot of biologic variability. And so serial measurements of GFR follow kidney disease. They don't follow the normal population. And what I'm seeing with a lot of EMRs is because you can graph all of your variables, you see that steep curve. So ignore your steep curve if it's in the normal range, unless you have another spidey sense that something else is going on. The other thing just to let you know about is that even though us academics like to talk about the equation, I have to say that starting tomorrow, December 1st, there's actually we're going to be using a new equation behind the scenes to measure GFR, something called CKD Epi, which I know. And the good thing about this is you're going to cure about 10% of your older women with GFRs in the 50 to 70 range. You're going to have had CKD on their profile, and suddenly their GFR is not going to be 50 anymore. It's going to be 62 or 63. So the way the new equation will impact you guys is patients with GFRs around that kind of normal band, 50 to 70-ish, especially in older people and especially in women, it will kind of push their GFR up. And so I'm happy to answer any questions about that afterwards, and there will be a little blip, hopefully that's readable, that'll come up. But just so you guys have heard it here first and know what's happening, and you can take the credit for fixing a lot of these people's kidneys. And it'll really be a good sobering exercise. We did run some preliminary data in BC to see how many people we think this will affect. It'll affect 10, 12, 15,000 individuals that would have had a GFR below 60, and now it won't be anymore. And this is just to remind you about the age caveats. So we tell our patients probably the same thing as you. So at the age of 20, we should have a GFR about 120 mils per minute. At the age of 40, somewhere around 80 mils per minute. And after the age of 40, I think most people know the kind of caveat that you lose a mil per minute per year. And so the average GFR of an 80, 85-year-old is around the 60 mil per minute range, and that's one of the ways that we kind of got the 60 mil per minute range. But if in our aging population, people are living older, and a GFR in the 55 to 75 range may actually be normal for them. It's not disease per se, it is normal aging process. However, when you're left at 60 mils and not 120 mils, you are at risk for acute kidney injury. You do have to watch medications, and we'll talk a bit more about that in talks to come. Yes?
There's a question from online. How often should GFR be tested if it seems to be decreasing but is still above 60?
Yeah, it's a great question. So if the patient's otherwise stable and you have a GFR of, say, 45 mils per minute, and 6 months ago it was 55 mils per minute, we would generally test at a 6-monthly interval. If you think something's going on with their patient and they're clinically unwell, then you'd probably want to test more often. But if GFR is in the 30 to 60 range and are just one number's less than the number before, somewhere in the 3 to 6 month range would be where we would test again, maybe earlier to the 3 month if you're worried that something is evolving. In our clinics, we have guidelines for how often we test, and we test generally every 6 months if GFRs are above 45, and if GFRs are 30 to 45, maybe every 4 months, 3 times a year. GFRs are below 30, then we get into every 2 months or so. Hope that answers your question. And so the next just little caveat is about elderly patients. So GFR measurements aren't that good in elderly patients. So when you hear, they can be used and they can definitely be trended, but when you hear our dictations and we say they're 85s, therefore I think their GFR of 45 mils per minute is an underrepresentation, that's why, because the evidence shows that once you get older, the GFR is actually the equation penalizes you a bit. So your GFR is a bit lower than we think it actually is. And that was one of the big controversies with GFR, but as long as we can contextualize, it's still a very good test to use to trend. So especially over 75, it may underestimate, and values in the 45 to 60 range may actually be normal. And over 85, the equation is quite problematic if you actually do more sensitive tests of their true GFR. So someone who's 77, 78, and their GFR is 45 to 48, and you repeat it over a 4-month period, their urine ACR is normal, their urinalysis is normal. You check some other parameters, and we can talk about this in the question period, but you'll note that PTH measurement isn't even in the guidelines to measure, and we can talk a bit about that, but calcium and phosphate are normal. The patient's unlikely to have significant kidney disease, and that just goes with that grid of albuminuria and proteinuria.
So I'm glad to hear that the new formula is coming out for some of us. When I trained, there wasn't a GFR. Some are more senior in the room will remember when we didn't have GFRs, we only had creatinines, and many elderly people we followed them along with creatinines 100, 110, and so forth. Didn't really get too excited about it, and then GFRs came in, and all of a sudden these people became high risk, and they had GFRs that were worrisome, and we wondered what we were doing wrong in primary care. And now, so you can see how the goalposts move a little bit, which is normal, but I think this is a step in the right direction to perhaps take some of these people that we were underestimating especially the elderly, that were underestimating their true kidney function. So the question is, how are we going to treat chronic kidney disease in primary care? What are our targets? And remember that we talked about, what do people with chronic kidney disease die from? They die from vascular disease, cardiovascular events for the most part, not unlike diabetes. And so when we're working them up, although I only alluded to the GFR and the albumin-creatinine ratio in terms of diagnosing CKD, knowing that people are in a high-risk category, we obviously need to order investigations that we would for anybody in that high-risk setting. So according to our disease patient, diabetes, and so ordering a CBC along with their lights and their creatinine and their lipid profile and their A1C and a urinalysis makes good sense. And the same rules apply in terms of treating things with lifestyle. So we all know that. We kind of gloss over it, but in fact we know that in the more literature that comes out, we know that less is more. We know that more medication doesn't necessarily make us healthier. We know that exercising more, stopping smoking, limiting our salt, alcohol, and so forth are really where the value is in managing chronic disease. So that healthy lifestyle, trying to get your sodium down below 2 grams a day. What are our targets for blood pressure? Well, we're going to hear from some experts about exactly about managing protein and blood pressure targets. For those of you who are lucky enough to read the This Changed My Practice bullet in the last kind of 3 months, Nadia wrote an excellent review of blood pressure in the setting of CKD. But just to summarize quickly, if you have diabetes and CKD, keep it simple. The 130/80 kind of goalpost is still where we're shooting. In the setting of non-diabetic CKD, the 140/90 is kind of where we're at right now. So in primary care, it's hard to keep all these numbers straight, and there's still some debate between different disciplines on this. But 140/90, kind of your target for CKD without diabetes, 130/80 with, okay? With respect to statin therapy or managing your lipids. So when you go to the, who looks at the CCS guidelines, the Canadian Cardiovascular Society guidelines on lipid management? Anybody? Some? So, I mean, you got to look somewhere. They have a great app as well. And really, we, rather than have each discipline try to come up with their own guidelines, this is always the struggle in primary care. We're given so many guidelines, and when we are given mixed messages about what to do. So we try to, in the new provincial CKD guidelines, try to keep things in line with the other guidelines. So CKD is a high risk factor. When you look at when you're risk stratifying your patient in front of you, which you try to always do, CKD, not unlike diabetes, is a high risk factor. And so if you're high risk, the guidelines would suggest you should be trying to lower your LDL by 50% or to a target of less than 2. These are for most patients. There are always exceptions. There's the young patient with CKD, like the young patient with diabetes who doesn't have anything else wrong with them. And there's some debate as to should we start people on statins in that kind of setting. But those are the exceptions as opposed to the rule. And I think those patients who you would seem to be lower risk, irrespective of their CKD diagnosis, maybe that warrants a good discussion with one of our experts in the room about whether it's worthwhile starting someone on lipid therapy for that. But I want you to remember that CKD, in general terms, makes you a high risk, puts you in a high risk category for a cardiovascular event. We know that there's some good evidence if you have diabetes and you have hypertension and you have CKD that ACE or an ARB would be the preferable medication to start with. Again, I'm going to defer to Nadia to really tease out the specifics around that, and you can ask her questions. And then, in respect to how tightly should we aim for people's diabetes control, we know that the two main causes of CKD in our Western world are hypertension and diabetes. So in primary care, if we're going to treat the big things well, we want to manage their hypertension and we want to manage their diabetes. Those are the major etiology factors for CKD, and shooting for an A1C which is in line with the diabetic guidelines of less than 7, with the caveat being maybe in the frail elderly, lightening up on trying to get down below 7 makes sense. So we know from the recent studies that being overly aggressive and shooting for unrealistic targets, tight targets, does harm. So we want to be mindful of that as well.
I just wanted to let you know so that you know if you're doing a good job. So I wanted to let you know, in a referred group of CKD patients, how good can we do? What is progression? What is fast progression? So we actually did a study here in BC where we looked in our CKD population with GFRs less than 30 over a year with hopefully optimal management under the guidance of CKD clinics. What happens to these people? And about a third don't progress at all. So their GFR at the start of the year and the end of the year are the same. About half of them have what we call moderate progression. So if they're anywhere between the 1 to 5 mils per minute per year, that's considered moderate. And over 5 mils per minute in a 1-year period, we consider rapid progression. And when you look at the reasons for that, things that we're going to talk about like proteinuria and others come out. So we actually try to inform the patient at the start that what they're kind of in for, so they don't come saying, I didn't cure my kidneys, right? So we control risk factors. But if they drop about 2 mils per minute per year, we say, actually, this is moderate progression, you're doing everything right, and this is actually what happens to the kidneys. And so we find it actually does help let the patients know kind of what is happening and helps them have some forward planning about what's going to happen to their kidney disease and not fixate on the number that they're actually worse than they were last time, because it's not like weight or other things where you can modify it and do things to get it better. You can get it stable and you can prevent rapid progression in some patients, but in others, it is the natural history of kidney disease. So I just thought that might be helpful for you guys to know what generally happens in these populations, even when they're quite well managed. Okay.
Okay, and so now who are we going to refer in primary care? That's really the question we have to ask ourselves as to who deserves to go to the renal team, to your local nephrologist. So I think that, setting your bar with the GFR of 30 and below makes sense, and those would be the recommendations. So less than that, it's time to have our nephrology colleagues get involved. When you have an ACR in the high category, so again, remember the low, medium, and high group, when your ACR starts to crest over 30, it's time. Persistent hematuria along with proteinuria is another reason to refer. Remember, isolated hematuria without CKD is a urological problem more than likely than a nephrology problem. And then the change. So in the CKD setting, that is GFR is less than 60, if we're getting a 10 to 15% change in the GFR, or that translates into 5 mils per minute, it's probably time to, again, have your friendly nephrologist get involved for some collaboration. And these are some other things to consider: refractory hypertension, potassiums that you're having a hard time with, refractory recurrent stones, and hereditary kidney disease.
I think for the interest of time, we'll skip this one. You will see it in the guidelines, and we'll talk a bit about it in the breakout session. So to finish, I just wanted to talk about the benefits of multidisciplinary team management for patients at high risk. We actually have shown here in BC that this is a graph showing your months after you start dialysis and then how long you live, your probability of survival. And it's broken down by how long you had been known to a multidisciplinary CKD clinic. And you can see at the top those known more than 12 months versus those not known actually have a mortality benefit. And the reason this is quite striking is when you look at anything else in the literature that proves a mortality benefit for our kidney disease patients on dialysis, it's about 0 things. So the fact that they were well prepared, had good access, and went on to dialysis in a controlled and thoughtful manner actually does save lives. And just a plug for multidisciplinary team, it's not just the nephrologist. We talk here as physicians about the nephrologist, but it's really the team that's probably doing the work. So making sure that you know when you do refer that the doctor that you are sending to works as a team, because clinic plus nephrologist is where all the benefit comes than a private practice nephrologist that doesn't have access to team-based management. And I just want to point out that despite, we say, a tsunami of chronic disease and everyone has diabetes and hypertension and we're going to have all these people on dialysis and we have to build units, the dialysis rate of growth is actually almost nothing. Almost none, and that's amazing because the bars that are going up are actually the CKD population, which are growing, which for obvious reasons. And I think the reason the dialysis population growth is not as several-fold. One, I hope we're doing a better job managing these patients. 2, we're having more transplants in BC, which is a wonderful thing, and having people off dialysis, but again, absolute numbers, that's small. And 3, we are realizing the benefits and the lack of benefits of dialysis. So in our clinics, about half of our patients with GFRs of 15 or lower have chosen a conservative care plan. And because all the literature coming out shows that in these elderly patients, that often it does not provide a benefit, and instead of getting better after starting, frailty increases, quality of life decreases. It's a very individualized decision, but we do hear rumblings of, nephrologists, they'll just put them on dialysis. Why are these people on dialysis? And We are very thoughtful when the decision is made with the team of who does and doesn't initiate dialysis. And with a GFR less than 15 mils per minute, in elderly patients, especially with coronary artery disease, there is actually quite good evidence that says starting dialysis will not make you live longer. And it definitely will not improve your quality of life. So a lot of these patients, it's not that we're doing nothing. They're part of a comprehensive conservative care path, and they can live quite an amazing long time with GFRs of 12, 10, 8. And the renal literature is pushing us to think about not starting early and starting just in time. And those numbers, usually by the time GFR gets around 6, if we're going to start, we're going to start. But it's more symptom-based and individualized to the patient. So I think you'll see that shift in your practice if you care for any patients at later stage of kidney disease. And you can also reassure patients that even though their GFR is falling, you don't have to say, well, they're close to stage 5, so dialysis is coming soon. Dialysis might actually never come, especially if they're in their 70s and 80s. So that's it for us. We just wanted to do a quick quiz after. And to summarize, it's a very common condition, but most patients we actually don't see, you guys see, and they won't ever progress to end-stage kidney disease. eGFR and albuminuria are both important predictors of both cardiovascular and renal outcomes. And end-stage kidney disease, for those that do reach it, is associated with a very poor prognosis. So you're close to your coffee. We have about 4 or 5 questions to go through, and then we'll go to the next speaker.
Thanks, Monica. Remember, these slides are all available to you. They'll be, are they on a stick?
The renal agency website will have them.
On the website for you. So again, who we're going to screen? High-risk people. If you remember, this is your little snap quiz here. A, B, C, D, E, hypertension, right? So screening is recommended for patients with hypertension, diabetes, heart failure, vascular disease, family history, or high-risk ethnicity. Which tests should be requested to screen for CKD? The serum creatinine, the urine albumin-creatinine ratio, the sodium to glucose, or the serum creatinine and the urine albumin to creatinine ratio, and the combination of those two really are the two. What's the major risk to patients with CKD? You've heard that clearly, I think. Cardiovascular disease. Which one of the following management strategies improves renal prognosis in CKD? Decreasing proteinuria, normalizing hemoglobin, folic acid, vitamin C, avoiding ACE and ARBs, and decreasing protein. And finally, I think there are 2 more. Which patients are at high risk for progressing to end-stage kidney disease? I think you also heard this, a more youthful person who's got lots of protein. And if you look through these examples, you see, one comes to mind here, and someone has an ACR of 90. So again, patients like this, irrespective of their GFR being normal, if their ACR is above 30, you should be starting to be concerned about that and connect with your nephrologist. And which of the following patients should be referred? Again, just trying to stress and overemphasize the importance of proteinuria, but in a young person who's 45, that'd be me, who has a GFR of 100, but a urine ACR of 120, remember that that's high risk. And just while we're talking about that, remember that 24-hour urines in primary care, probably we don't need to ever do them. And I think some of the residents and the younger doctors know that, but I was trained in an era when we did do it. And if you're ordering a 24-hour urine, you probably should be asking yourself, why am I doing this? ACRs have supplanted the 24-hour urine for total protein. There are other reasons to do 24-hour urines, but for looking for protein, you don't really need to do it. And kind of a rough ballpark is you can take your ACR and times it by 10 to give you the 24-hour excretion of protein. It's not exact, but it's a good ballpark. So thanks, everybody. And are we going to have some questions now?
I think we'll go through the speakers if that's all right. If you just take a little note of your questions, and then we'll ask after the first four speakers, we'll answer any questions. Are you going next, Abeed? Go first.
Oh, goodness. Okay.
It's okay.
It works.
Yeah.
Okay. Sorry. Thanks. Good morning. So first of all, just a thank you to the organizing committee, Monica, John, and everyone else just for having me back. We did some of a similar event last year, and only for the speakers that were here, I was duly embarrassed by Cliff, who dressed really well. So I decided I would dress up this year just to try and keep up with the Joneses. The next thing that you'll notice is that there may be some slides that look familiar to you, and that's because Monica's very kind, and while I didn't borrow any of Cliff's clothes, I did borrow Monica's slides. So there you go. I don't think her clothes would fit. So hopefully that sort of keeps the theme together, though, that we're, you'll see some repetition and some same ideas, but I guess it's to drive that point home. And hopefully if the learning principles are right, if we tell you enough times, then you'll just do it so that we stop bothering you. So what I hope to do is just talk about how to measure proteinuria in clinical practice and a few caveats for measurement, understand some of the prognostic significance of proteinuria, how and when to treat, and again, back on the referral theme. And we'll walk through. So again, a few cases just to keep things in mind, and I'm not really going to answer this when we start, but we'll come through it, and you probably actually all know the answer already because the introductory talk should have hit all of these highlights. So a non-diabetic 62-year-old with normal blood pressure, a mildly elevated ACR, a normal creatinine, and a normal urinalysis. And so the questions that I think should go through your head is, does this person have CKD? Is there anything that you tell this person about significance? Does this mean anything? Do you treat? And do you refer? So some sort of food for thought to keep in mind as we move through. Okay. This is a slide that you saw that Monica showed, again, talking about the burden of what we call chronic kidney disease. And again, in the top two categories where you have a normal GFR, if you look at the numbers, that's over half of what we would consider chronic kidney disease is actually patients with a normal GFR, and those would classically be ones with microalbuminuria in old terminology. And I've left it up there just so you can think about it, and we'll talk through what those mean, and I'll show you some other caveats. But again, like John, training, I always thought microalbuminuria was a different protein from albumin because it was small albumin. So it's always been a bad term, and it's working its way out. And so I apologize because I've left it in a few times. But and then if you look at percentage of patients with, again, new terminology and old terminology, so the new terminology is going to be low-grade proteinuria or an albumin to creatinine ratio of 30 to 300, just in the general population, where are you going to find these people? And we'll talk about why you might see some of these things. But as you age, you could see up to 40% of the population having low-grade proteinuria. So it's very prevalent. It's out there. And I think we need to know what it means and what to do with it. John answered this. So if anybody gets it wrong, you will blame John for not teaching well. So again, there is no role for 24-hour urine collections in primary care. We will still do them in very specific cases, but even in a nephrologist practice, I think you'll find that we do very few 24-hour urine collections now. For specific renal-related glomerulonephritis, we will, but the ACR has really supplanted that in our practice as well. So how do you measure proteinuria? The first thing to note is that your dipstick is only going to pick up about 300 milligrams of albumin or ACRs of 30 or higher. So the dipstick in and of itself is not really sensitive enough. So as a screening tool, while we want a urinalysis, you need to do more than just the dipstick. And so the ACR, as you've heard, we'd like to have 2 or more samples that are positive, bearing in mind that your proteinuria will vary quite a bit. There is significant day-to-day variation. It is affected by, amongst other things, blood pressure control, glycemic control, anybody who's got a fever or is sick for any other reason, a urinary tract infection, and even those doing heavy exercise. So there certainly are cases where people will be out out running or out at the gym and doing it shortly thereafter, and you can get a positive ACR based on that. And so you do like to have people rested and well controlled. So don't do it when they're sick. And again, no need for 24-hour. Okay. And as you look at what are you going to see, what has been sort of, we still use some of the overt nephropathy and nephrotic range proteinuria, but really for your purposes, if you look at what was microalbuminuria, again, is that ACR 3 to 30, normal less than 3, your dipstick would be negative, and you can get the gauge. And then again, back to John's point, as you looked at how do you convert that to a rough idea of how much protein you have, it's just moving a decimal place and keeping it as milligrams. So somebody with 300, an ACR of 300 milligram per millimole is roughly 3,000 milligrams per day, or roughly 3 grams a day of protein. And that's the rough gauge that we use as well when we think about what these numbers actually mean. But again, your dipstick will come back negative often in the low ranges, so you do need to do that ACR test. Just having a positive ACR, again, at least once, and we probably are still doing this more often than once, and as nephrologists, I think we're getting our heads around maybe not having to do as many urinalyses, but it's kind of our crutch. But don't forget microscopy, because there can be lots of other abnormal findings in microscopy that will point to other diagnostic things, other reasons to refer, and other investigations that may need to occur. So again, red cells with protein, we think about kidney-related things, abnormal red cells, abnormal casts. These are all things that the nephrologists need to look at, but please do a microscopy. So as we look at protein and risks of proteinuria, and you've heard that cardiovascular disease is our big nemesis really in kidney disease. But if you were to look at two patients, and so a GFR of 45, so an abnormal GFR, but a normal ACR, versus cardiac risk for somebody with a normal GFR and a bit more protein. And the reality there is that the risks are about the same. So that's really been the genesis of the new definitions to tell you that having the proteinuria or having abnormal kidney function both portend an increased cardiac risk, and they both should be classified as chronic kidney disease. This, again, is the slide that Monica showed you. And you do see there that as your GFR worsens, your risk of death goes up dramatically. And it is a problem. And again, a very small minority of our patients actually come to require renal replacement therapy. Most of our patients with chronic kidney disease will die before ever coming to need renal replacement therapy. And this is, again, the same thing that with early stage CKD, you're 5 to 10 times more likely to die from a cardiovascular event than you are to progress to end-stage kidney disease. So in terms of our management focus, again, we're managing cardiovascular risk factors. It ties in and helps us with minimizing progression of renal disease, but really that's our very big focus. Again, when you look at proteinuria, it does correlate very well with cardiovascular disease. And if you look at albuminuria along its whole length of distribution, and the sobering thing here is that even in the lower ranges, maybe within normal, you actually see a linear correlation with cardiovascular events, regardless of what the GFR is. So actually having proteinuria in and of itself is very risky for patients in terms of long-term health outcomes. Things to bear in mind when you look at diabetes and you look at chronic kidney disease in diabetics, again, bringing back the point that proteinuria is important. If you look at the yellow line on this graph, I'm not going to try to play with the mouse because I'll make a mess of it. You will see that you actually have presence of proteinuria well before you start to see GFRs drop. So that GFR of 60 is probably going to come into play on that graph at about 20 to 25 years of diabetic duration. and you're starting to see development of proteinuria at 5 or 7 years. So the development of proteinuria will antedate your actual loss of kidney function, and it's a marker of kidney disease. And hopefully at this level, if we intervene early, we can actually slow that progress. But if you wait till you see an abnormal GFR, you've really waited too long. So more patients to think about. A 70-year-old with peripheral vascular disease, well-controlled blood pressure, normal GFR, treated with aspirins and statins for his dyslipidemia, has a slightly elevated ACR that's real, done on 3 occasions, urinalysis is normal. What do you do for these patients? And the real question is, would you start ACE inhibitors, angiotensin receptor blockers, or do you just try to optimize current therapy? And I think in this case, given normal blood pressures, I think most of us in the room would argue that we would continue to optimize cardiovascular risk factors. There may not be a huge push to start the ACE or ARBs at that level, although we're getting up where we can certainly think about it. So simplistically, I think if you were to look at when would you actually start treatment, and who would you treat with ACE inhibitors or angiotensin receptor blockers in order to try and minimize proteinuria? This is it's not written in gospel, but I think it's a fair summary of what we would do. That, if you're diabetic and you're non-hypertensive and you have even low-grade proteinuria, we would treat. There is reasonable data to suggest that actually trying to minimize that proteinuria and treating diabetics early with ACE inhibitors and angiotensin receptor blockers can limit the progress of diabetic kidney disease. Some of the nephrology pundits that are big in the ACE inhibitors and angiotensin receptor blockers would have you believe that you can potentially reverse some of the damage. I'm not sure we're there yet, but we would certainly advocate early therapy. If you're diabetic with hypertension, even if you don't have a lot of protein, I think there's good evidence that we would say we would start it, and that would be your drug of choice. If you're non-diabetic and non-hypertensive, I think we probably push that window a little bit further. And, if you got over an ACR of 30, we might treat with an ACE inhibitor specifically for proteinuria reduction, not for hypertension management. And again, if you have hypertension, we move that earlier because if you're going to use an agent to treat, you might as well try and get additional bang for your buck and get the proteinuria lowering strategy out of that as well. And what do we do for therapy? And I think this has all basically made it through, but there certainly was a push a number of years ago where we combined ACE inhibitors and angiotensin receptor blockers. We don't do that anymore. It's one or the other. The direct renin inhibitors are not combined. So really one or the other. And back again to John's point, diet, exercise, lifestyle modification, and diuretics can often be helpful because they can enhance the antiproteinuric effect of the ACE inhibitors and angiotensin receptor blockers. So what do we do? 40 should probably read 30, but reduce the urine ACR really as low as possible, with another caveat there that when we treat our patients, sometimes despite best therapy, they continue to have proteinuria. And we will push, but there are limits to how far we can push, and sometimes you just have to accept that and know that those are the patients that are at higher risk for progression. But certainly try to minimize proteinuria as much as possible. Keep blood pressure when you have protein at less than 130/80, but Nadia will tell you more about blood pressure, and I'll try not to say too much. We'd like to stabilize creatinine and eGFR. Again, those rates of decline, you want to try to get them in that 1 to 2 range, down to the low moderate range as much as we can, understanding that they likely will have some decline of kidney function. We educate patients about things that are risky for kidney disease, risky for acute kidney injury. And in our clinic, in our multidisciplinary clinic, again, with counseling from pharmacists, from nurses, all of our patients are counseled regarding what to do in the face of an acute illness. And they hold ACE inhibitors, they hold angiotensin receptor blockers, hold their diuretics, hold their metformin if they're diabetic. And they actually get written documentation about this. And I think, again, that harkens back to the utility of having a multidisciplinary clinic, because we have people to help us to do that. I'm not sure that we'd be as good at it by ourselves in our offices, but I think that's some of the benefit from the clinic. Again, when we look at referral, who do you refer? Again, this pattern is going to look very much like that other treatment pattern is, and a lot of the heat maps that you'll see in care, that as you get further down to the right side of that heat map, you start to get into more trouble and more concern about kidney disease. So obviously low GFRs, high protein are referral. Anybody with high protein likely needs to be seen. We may not impact that proteinuria a whole lot. You may be doing everything right. Their blood pressure may be well controlled. They might be on ACE inhibitors, angiotensin receptor blockers, doing everything they can. But it's still worthwhile, I think. And then, again, as you sort of add the combination of a lower GFR and a little bit of protein, it gets to be worthwhile. Again, cardiovascular risk reduction is really the big push that we look at, given that that's what tends to be particularly risky for patients. So, again, back to our initial woman that we started off the discussion with an ACR of 7.8 to 15 and normal kidney function. Would you tell her that she has CKD? Yeah, I guess based on what we've talked about, yes, she does have CKD. Is there significance to that low-grade protein? Yeah, in terms of cardiovascular mortality and all-cause mortality, it does actually portend a higher risk. Would you prescribe therapy? I'm not sure with normal blood pressures that you would necessarily be pushed to try and prescribe therapy, but I think it comes back to, if you want to call lifestyle therapy, or if that's a prescription, but I think it comes back to monitoring for risk factors, watching for risks of acute kidney injury, diet, exercise, other cardiovascular risks. So specific therapy in terms of a medication, probably not, but lifestyle, yes.
There's a question from online.
Okay.
Is there a particular ACE or ARB that is more beneficial?
No. I'll look at Cliff because he's our pharmacist here. No, they're all, I think generally they all have a class effect. And so I wouldn't, I don't have preference for one over the other, and I don't think any of my colleagues feel that there's any sort of particular benefit to one over the other. So any of them is fine. And then in terms of referral, I think, as John alluded to, we really see the tip of the iceberg as nephrologists, and this is going to be a fairly common primary care issue. And so this isn't somebody who necessarily needs to be referred. It's somebody who needs to be followed and watched. But I think this is the burden of primary care disease that you guys all will see and manage. So at the end of the day, I think what hopefully you'll take away from this is proteinuria is common. It's associated with cardiovascular and renal outcomes. And the cardiovascular outcomes are more prominent. We all hope our ACR is normal. For those of us that have failed insurance physicals in the past, but passed them on the second time, you do hope it's normal. You want to treat those elevated ACRs in diabetes and hypertension, and it's an ACE or ARB. If you don't have diabetes and hypertension and you have low-grade proteinuria, specific treatment is less clear, bearing in mind that we will treat cardiovascular risk factors. And again, that referral to nephrology with those ACRs consistently above 30. So I will end there because we'll save questions for after. No, I don't know what to do. Okay.
And I think I failed to introduce Dr. Jamal, who is a clinical nephrologist at St. Paul's that works along with me, and Dr. Adam White, who we're actually fortunate to have an endocrinologist talk to us. We work together in an integrated clinic at St. Paul's that combines the specialties, so we hopefully give one message to the patients when they come for evaluation of their kidney disease in the context of diabetes. Thanks, Adam.
All right, so thank you, Monica, and thank you to the organizers for having me. As Monica mentioned, I have the privilege of working alongside them in the Integrated Care Clinic project. We've been at it for a long time now, it seems. And, I think we all feel it's really nice one-stop shopping for a lot of our CKD patients who also struggle with diabetes. So, just a little bit of another pitch to the multidisciplinary clinics. So what I want to do for you, and what I've been asked to do hopefully in a practical way, is to give a broad review of the current agents that we have for type 2 diabetes, understanding that this is it's a very, very rapidly expanding population of agents that we have available, and it's not getting easier for primary care physicians to know what to choose. Think about some of the indications or contraindications in some of the type 2 diabetes depending on stages of CKD. And then a little bit of a talk about what is the evidence, and in particular with metformin, about all of the angst we tend to have about it. So a lot of this is based on information that is readily available to you from the CDA guidelines. And I also will make a small pitch to the recent Canadian Journal of Diabetes, October 2014, which actually has an outstanding review on what to do with diabetes medications in chronic kidney disease. So if you have a rainy afternoon or something and want to pick a journal up to read, it's a good one. So you all know the basic concepts of diabetes management. Pick where you're starting in terms of glycemia. Metformin is still our baseline, along with lifestyle modifications. And then the whole concept of trying to individualize therapy with a goal of getting their glycemic target within 3 to 6 months. Now, John alluded a little bit to the hemoglobin A1C targets, and yes, the guidelines do jibe that our overall goal for the vast majority of patients is a hemoglobin A1C target of less than 7%. There is this concept of loosening that target a little bit in the setting of significant comorbidity, expected shorter duration of survival, etc. The important thing to this statement, though, is that this does not mean that we ignore diabetes management. And unfortunately, in some realms, that's the way this has been interpreted, that we just don't do anything. That's not the case, because severe hyperglycemia has its own negative problems and risks in and of itself. I will make a little pitch to the lower end, though, because there is good evidence supporting that if we can safely bring hemoglobin A1C below a 6.5% target, and this comes out of the ADVANCE trial from several years ago, that we may further lower the risk of microvascular disease, and in particular risk of nephropathy and retinopathy. But that caveat is balancing it against the risk of hypoglycemia. You've probably seen this before, the overall sort of flow of diagnosis of diabetes, what should we do? And I'm not going to belabor this to any significant degree, other than moving to this page where after metformin, if not at target, the list is broad, and really it doesn't tell you exactly what you should use second line. And that's always the question that we tend to have is, well, what should we use second line? The general flavor of the Canadian guidelines, and indeed most of the diabetes guidelines around the world, is the target of A1C improvement, trying to prevent hypoglycemia, and thirdly, strategies that may be either weight neutral or weight beneficial. So that's the so-called triple target. But in our CKD patients, of course, we run into troubles with a lot of these medications. I won't belabor this. We've been through this particular slide many times, but just the various stages with the whole concept of that above 60 is still normal renal function, although there can be some kidney damage. This did not come up very well, but it's intended to not come up very well. This is adapted from the Canadian guidelines, and it basically gives you a one-page snapshot of the current diabetes medications that are available, and some sense of what to do with them. But I'm going to walk through really what are the most common agents you're going to have patients on at this point in time. I'm not going to go through every single agent there. So, metformin. Metformin causes a lot of angst, especially as GFR starts to dip a little bit. And we see all sorts of strategies, most of them quite reactive to any element of a GFR drop. So in the individuals with GFR greater than 60, there should be no concern whatsoever about having to reduce metformin and basically optimizing it to whatever a patient can tolerate dose-wise. The guidelines do recommend that you start to think about reducing dose in stage 3 kidney disease. But as you're moving into stage 4 or 5, so GFR is getting down below 30, this is honestly where you need to start to have the discussion about whether it is still the best agent. And we often have a lot of back and forth about this in the clinic together and trying to decide when that threshold is. In some ways, I agree with the statement that the EMR is troublesome when you see that graph with the plummet of the GFR. It gets you all excited and worried. But in other ways, it's helpful because following that trend, especially when you have individuals in this lower range of GFR, that as much as anything helps you to think about, do I think this person's progressing a little more rapidly and that metformin could potentially cause trouble in a relatively short window of time for this person? The overall comment is that certainly metabolites can accumulate in lower GFRs, but especially in an acute event. And that's really what we need to think about with metformin, is acute kidney insults on the background of some element of chronic function. So this is a paper that one of my colleagues at St. Paul's published in CMAJ a few years back, and he entitled it was a commentary actually, are the contraindications to metformin contraindicated? So he looked at this overall broad worry with metformin of lactic acidosis, and in individuals with type 2 diabetes, there's really not much of a different rate of lactic acidosis over in the general population beyond non-diabetes patients. So things that can cause lactic acidosis are acute kidney injury, acute congestive heart failure, MI, sepsis, and the overall rate is maybe around 8 to 9 events per 100,000 patient years. But it occurs in both type 2 diabetes with or without metformin use. So it begs the question generally, is really metformin the culprit here, right? The broad population rate, I'm not sure why these are popping up kind of funny, but they are, is rate average 9.7 to 16.9, and that 8 to 9 events per 100,000 patient years in a type 2 diabetes population. Don't know what happened here. So the statement is that, is this lactate formation more coincidental and possibly not related to metformin? So a little more evidence that suggests it may just be a bystander as well, because there's some cases of lactic acidosis developing in patients with entirely normal renal function and even at very wide dose ranges of metformin. So the concept of reducing the dose to reduce the risk, the evidence doesn't necessarily suggest that that's a right or wrong thing to be doing. And the other important part is that in individuals who have presented with lactic acidosis but on metformin, is when they actually check serum metformin levels, they don't really correlate with the development of lactic acidosis. So there's a lot of controversy over this. Overall, we have to think big picture about what are we trying to do. And we've heard a lot about prevention of vascular risk, etc. There's maybe about a 1% 10-year risk of a lactic acidosis event using metformin. We have to balance the risk with the benefits. So if we look back to UKPDS, metformin, the metformin arm of that study, led to a 5% reduction in diabetes-related deaths. And when we followed this population out, to the 20-year follow-up of UKPDS, we started to see improvements in macrovascular disease. So diabetes-related death, 7% reduction in all-cause mortality, 6% reduction in MI, 3% reduction in stroke. So metformin does good things. And we have to think about the balance of the relatively low risk of a phenomenon that may or may not occur. So the controversy probably will never be entirely answered with metformin, but I think the important thing is don't be overreactive with completely removing it from your patient's regimen unless you're very concerned about an acute insult or rapidly declining renal function. Acarbose is not overly commonly used, but working in the Vancouver area, a lot of our Asian immigrants, it's a very popular agent. It's the not most pleasant agent to take, but it works, and interestingly, it's one of the few diabetes medications that has some reasonable macrovascular benefit evidence behind it. But there's really just not a lot of information about what to do with it in renal function. So really no dose adjustment is suggested down to about a GFR of 30, but just because of limited information, the recommendations are consider alternative when they're declining any further. The DPP-4 inhibitors, of course, are quite popular agents, and I'm sure all of you have many patients on these. We have 3 of them available in Canada. So we have linagliptin, saxagliptin, and sitagliptin. The linagliptin is a hepatically metabolized product, so there is no dose adjustment required for it at any stages of renal function. However, this does not necessarily insinuate that this is the agent to use in low renal function, because that's not where we have any evidence to suggest that it's a preferred agent, but just that we don't necessarily have to worry about dose adjusting if an individual is on it. And of course, the caveat really is there's very limited data for almost all of these agents in end-stage renal disease or patients on dialysis. Saxagliptin, no dose adjustment above a GFR of 60, but consideration to a half dose or 2.5 milligrams in GFRs less than 50, and again, limited data at lower ranges. Sitagliptin has a stepwise dose reduction recommended for it, and I do tend to see an awful lot of people that come in with lower renal function on full dose sitagliptin, and I think it's just a sort of a lack of understanding that it is one that should be adjusted. So they recommend a reduction to 50 with GFR between 30 and 49, and then down to 25 at anything lower, with this caveat that there could be a risk of accumulation, but we don't really know whether that's going to be a harmful phenomenon for patients. I mean, of course, we don't really worry about hypoglycemia with these agents. GLP-1 receptor agonists, so we have available in Canada exenatide, which is not overly popular, but it is around a little bit, and then liraglutide, which is much more commonly, although still relatively low percentage-wise in terms of use. With exenatide, they recommend going down from the more potent and helpful 10 microgram twice daily dose to 5 microgram twice daily. But again, with limited data at low renal function to consider alternatives. And similarly with liraglutide, again, a lot of it due to just not a lot of information in renal populations. The product monographs suggest considering alternatives. However, there are some fairly reasonable prospective studies that are going to help us to understand the safety of these agents in patients with lower renal function. So I think it is a big question mark of what to do here, and that probably monographs will change as evidence starts to accumulate in these populations. Sulfonylureas, again, cause a lot of angst, especially as renal function starts to drop. And glyburide is generally the one that we see people running into the most trouble with hypoglycemia. Really because a bit of a two-step phenomenon. One is that glyburide's renally cleared, and the second is that in lower renal function, insulin half-life is longer. So you get a little bit of a double hit there. So the guidelines and monographs do suggest moving away from glyburide as a preferred secretagogue agent with GFRs less than 60, or just be very cautious and monitor closely. Glycoside, however, is not 100% a slam dunk to use either. It's hepatically cleared, but with that higher insulin half-life in a secretagogue effect, you've got to be cautious at people with lower GFRs due to higher hypoglycemia risk, and again, limited data in end-stage renal disease or dialysis patients. Thiazolidinediones are, really not on the ins anymore, but there's still people out there. We don't really have to have any concern about adjusting them for renal function, but one of their side effects is the risk of volume overload, potentially heart failure, that sort of thing. So really in individuals with low renal function, you just have to be very cautious about the worsening of volume status with them. And I think most of us probably will start to shy away from a thiazolidinedione as GFRs are getting down below the 20 or 30 range due to volume overload concern. You may have had industry knocking on your door about the newest player in the block over the last few months. So we have in Canada now one of the SGLT2 inhibitor class available, with many more waiting in the wings. It's going to be a interesting and competitive market in the next few months. But we currently have canagliflozin at 2 doses of 100 and 300 milligrams. In normal renal function, we have no concern about dosing, so that would be GFR greater than 60. The current guidelines, Canadian guidelines, do not have any information about SGLT2 inhibitors because basically they were not on the market with this iteration. But the product monograph for canagliflozin is that you shouldn't really be starting the agent if their GFR is less than 60. If they are already on the agent, they should probably stay at the 100 milligram dose with a GFR between 45 and 60. And if a GFR is below 45, certainly don't start it, but probably stop it. In the end, really, there's some suggestion of worse adverse events with lower GFR, but the truth is the practicality of efficacy. These agents do require good renal function and filtration to actually work. So that's really my important take-home for you with the SGLT2 agents. There are a number of prospective studies with many of the agents in this class looking at perhaps other benefits in renal function, but those are all question marks at this point in time. It's going to be a few years till we really have the answer there. Insulin. So I already touched base on a little bit of this, but with declining renal function, half-life of insulin increases, so we have to be, if you have patients already on insulin, mindful of that. That their risk of hypoglycemia is going to go up. I'm always very kind of concerned about the previously poorly controlled type 2 diabetic who suddenly their hemoglobin A1C magically drops to 6.1% and we have done nothing. It usually means that their renal function has dropped quite a bit and all of a sudden their insulin residency time is that much better and they're just getting a lot better insulin effect. So we have long talks about hypoglycemia with patients who suddenly have that shift in their control. It may look great, but it can be quite worrying. They need to be aware to increase their home blood glucose monitoring frequency because generally you're going to need a dose reduction in insulin. But in the end, with all of the caveats of the oral agents, insulin probably remains the most important tool for diabetes management in patients with lower GFR, and certainly when we're moving into dialysis situations. Peritoneal dialysis in particular can be quite problematic due to exposures to high sugar concentration solutions, and they really do require kind of specialist management to help out most of the time. Think about the sick day, and I think there was some allusion to sick day previously, but on my end, this is from the guidelines as well. Think SAD man, so sulfonylureas and metformin are the two on my end that you've got to be very careful of in patients who are unwell. And this is again how the multidisciplinary team can help an awful lot, is explain to patients what a sick day is and that sick day management. So those are the two acute event agents we have to watch. And this is a nice little card, actually. If you go to the CDA website, diabetes.ca, you can download this and print it and have it available to you in your office. It's readily available. So my bottom line is that most of the hypoglycemic agents are going to require some consideration of their utility, efficacy, risk with declining GFR. Really, there's none of them that you're going to be able to just not think about. In acute events, a rapidly declining GFR, you've got to have a lot more caution. This is the big thing. If you take away, you need to give. And that's probably the biggest problem that we tend to see, is the metformin gets stopped, but then nothing else is offered in its place. So these people who had previously reasonable glycemic control, all of a sudden they're well out of hand, and it's a struggle to get them back in line. And again, the concept of the acute renal event, a lot of these people recover back to their baseline, and sometimes even better. There's no reason they can't potentially go back to an agent like a secretagogue, like metformin, if they've had recovery and you're happy that their recovery is reasonably stable. But don't just keep taking. You need to be a giver. So I will leave it at that, and I think it's going to be an overall question window, but I can answer any questions that may be out there right now. Stunned silence, even online, hey? Okay.
Thanks, Adam. So our last speaker before the break is Dr. Nadia Zalunardo. Nadia is the director of the kidney clinic at the VGH site and is going to talk to us a bit about the cardiac aspects and blood pressure aspects of managing patients with kidney disease. And it looks like we're running just the littlest bit over time, so we'll shorten the Ask the Expert, and we'll be available for any questions. And during the break, we'll kind of do Ask the Expert with the break, and then we'll be right on time for the second part of the morning.
Okay, thank you, Monica. Good morning, everyone. So I think in the next 30 minutes or so, you'll find that I'm reinforcing a lot of the messages from the first two talks, especially. So I do want to spend a couple of minutes just reinforcing the strong link between cardiovascular disease and chronic kidney disease, which is sort of the so what of this whole talk about blood pressure and heart failure management. And then I'll spend some time on the blood pressure targets and preferred agents for blood pressure control in CKD, and finally on managing patients with both heart failure and chronic kidney disease, which is a huge challenge, and not only for you guys, but also for us. So this slide comes from a large meta-analysis published last year that looked at the impact of chronic kidney disease on life expectancy, and again reinforcing the message that CKD is bad for your long-term outcome. And on this slide, on the y-axis, we have life expectancy in years left, and on the x-axis, we have index age of the person in years. And each of those lines represents a stage of chronic kidney disease. So the upper two green lines show stage 1 and stage 2. The middle line is showing stage 3 CKD, and the lower reddish lines showing stage 4 and stage 5 chronic kidney disease. And the impact of chronic kidney disease, especially later stages, is true for people at all ages. So in other words, if you're 80 and you get CKD, your lifespan is going to be shorter than if you were 80 and didn't have CKD. But really what I want to highlight on this slide is that the impact of CKD on life is especially true in younger patients. So if you take the 30-year-old with stage 1 or stage 2 chronic kidney disease, which is shown there in the numbers on the left, that person in the green lines will still have about 40 years of life left, which is still shorter than what they would have had if they didn't have chronic kidney disease. But once this person enters stage 3B chronic kidney disease, so now a GFR between 30 and 45, their estimated life expectancy is only about 24 years. So that's living to the age of mid-50s. More dramatically, once this person gets stage 4 or stage 5 chronic kidney disease, their life expectancy is only 12 to 15 years. So it is really a dramatic effect on life expectancy. What are these people dying of? Well, we've already heard this, and this is just reinforcing that point as well, that kidney patients die of cardiovascular disease. And this is a simple slide basically showing on the y-axis the proportion of patients dying of a specific cause, and on the x-axis, the stage of chronic kidney disease. So as you go to the right, more advancing CKD. And cardiovascular disease deaths is shown in the blue bar. And so you can see once someone drops to a GFR of 30 or less, at least 50%, and for people with GFR less than 15, well over 50% of deaths are due to cardiovascular disease. So chronic kidney disease is a flag for you in your practice as a cardiovascular risk factor, and something that you need to manage aggressively. And again, just repeating this one more time, that most patients with chronic kidney disease are much more likely to die from cardiovascular disease than to ever get to kidney failure. And this is particularly true for the older people. So moving on then to treatment of cardiovascular disease in people with chronic kidneys, and I'm going to focus on blood pressure, but I can hardly resist an opportunity to say that, at the end of the day, we do need to spend time with our patients on counseling about lifestyle modification, lifestyle intervention, which is, a lot harder and takes a lot more time than prescribing Ramipril. But smoking cessation, alcohol in moderation, optimizing body weight, and physical activity are all things we should be suggesting to these patients in general. The other important thing in chronic kidney disease is to counsel on sodium restriction. Chronic kidney disease ultimately is a salt-sensitive state, especially people with more advanced chronic kidney disease. So you get more bang for your buck counseling a CKD patient on sodium restriction than you do in a non-CKD patient, because it's going to have more impact on reducing their blood pressure and volume status. So the current recommendations are for less than 2 grams per day of sodium. And in the kidney clinics, we counsel patients on how to read food labels. Because as we all know, there's plenty of hidden sodium in many of the products that a lot of people eat every day. And this is just a graphic about the Salty 6, which identifies a lot of the common culprits, which mainly include processed foods, but store-bought breads and rolls, cold cuts, canned soups, and interestingly, poultry and other meats are sometimes injected with sodium phosphate to give them flavor. So people even need to read the meat labels. So we'll move on now to the pharmacological intervention. So we've already heard about blood glucose control and diabetes. I will just make a cursory comment about lipid-lowering therapy, and that's consistent with the message from the first talk is CKD is essentially a kind of a non-traditional cardiovascular risk factor, and for those patients with CKD, especially in middle age or higher, statins are recommended. And finally, I'll move on now to blood pressure control. So this is a controversial topic, despite the fact that we might think we already know the answer, and despite all the research that's already been done. I consider blood pressure targets in CKD to still be a moving target. So what we are telling you today is probably going to change at some point in the not too distant future. And, I think some people get a bit passionate about what they think the right answer is, which, has led to some debate in the literature, but ultimately we still have a long way to go in terms of knowing really what the blood pressure targets should be. So my own personal view is that the CHEP guidelines, which are updated annually based on evidence, are very reasonable, and I think it's largely what we're using these days. And I will also say that these guidelines are harmonized with those of the Canadian Society of Nephrology and also with the Canadian Diabetes Association. So all three sources should be telling you the same thing. And in these guidelines, basically, blood pressure targets are broken up according to diabetes status. So in a diabetic, the blood pressure target recommended less than 130 over 80 millimeters of mercury, and in a non-diabetic, less than 140 over 90 millimeters of mercury. And I've just put in green there the grades of evidence upon which these targets are based. And mainly it's there to highlight that it's not all based on grade A evidence, which is why these things might change in the longer term. What I like best about these guidelines, though, is that they're telling you to use some sense when you're looking after your patients. And that is to say that you have to use caution in people who you're worried that a substantial fall in blood pressure due to therapy might not be well tolerated. So this includes elderly patients, patients with autonomic dysfunction, patients in whom you've already tried to increase antihypertensive therapy and they didn't tolerate it. So I think that's kind of a newer message that's come out. Sometimes you may actually get a letter back from one of the nephrologists using a different blood pressure target. And there is some different messaging and different guidelines out there. And I've just highlighted the ones from the KDIGO, which is sort of an international kidney disease group that produces guidelines for the world, essentially. And from the kidneys point of view, at least this guideline point of view, it's all about the protein in the urine, and the blood pressure targets are based on protein in the urine. So I just putting this out there mostly to highlight to you that you may see some inconsistent messaging, and this is just a different interpretation by a different society regarding the same data. But I do think that the CHEP guidelines are very reasonable and will stand you in good stead. But these guidelines as well suggest tailoring treatment, especially in elderly patients, considering age, comorbidities, etc. So I think what we're moving to is that one size does not necessarily fit all, that you do need to individualize blood pressure targets, taking into account what the guidelines are, but using sense in your own patient. And this is my seasonal slide that at the end of the day, we are all like little snowflakes. So what blood pressure agents do we use? So what I've put on this slide is the grade A, for the most part, based first-line antihypertensive medications in CKD. And these are split up according to proteinuria. So people who have no proteinuria, ACR 3 to 30, which is microalbuminuria, which I know is technically a term I shouldn't be using, and then ACR greater than 30. And then that's further split up into people with non-diabetic CKD and people with diabetes and CKD. So for the diabetics, it's pretty easy. Diabetic with hypertension, use an ACE or an ARB. That's all grade A evidence. For a non-diabetic that has a lot of protein in the urine, ACR greater than 30, an ACE inhibitor is actually the grade A evidence, ARB is grade B evidence, but basically ACE or ARB for those people as well. For the people with ACR 3 and 30 and no diabetes, this is a slight inconsistency if you're paying close attention to the earlier talk and this one. Actually, the CHEP guidelines don't suggest a specific agent for those people. Practically speaking, I think many of us end up using ACE inhibitors and ARBs in these patients as well. But I highlight this in part to, relieve you of some guilt. If your patient doesn't happen to tolerate an ACE or an ARB, you're not doing them a major disservice to use a different agent. And then in non-diabetics with CKD that have no proteinuria, again, it's the agent of your choice. So a few other practical strategies for blood pressure management in chronic kidney disease. And the first thing is, unfortunately, combination therapy is usually required. You're highly unlikely to get away with a single agent. And in terms of what you will do, what you might consider for add-on therapy, just remember that, again, CKD is a salt-sensitive state, so diuretics are often effective as add-on therapy. And if someone's got relatively preserved kidney function, so GFR is still above 30, thiazide diuretics are often useful. For people who are volume overloaded or who have more advanced chronic kidney disease, in those people you may want to opt for a loop diuretic. In diabetics, in terms of second-line agents, the CHEP guidelines actually suggest, if the patient is not volume overloaded, that a dihydropyridine calcium channel blocker be the next agent of choice over a diuretic. And that actually comes from the results of the ACCOMPLISH trial, which showed a reduction in primary outcome with the ACE plus the amlodipine versus ACE plus thiazide. And just, I think Dr. Jamal mentioned this as well, that, we don't combine ACEs and ARBs anymore. Although you might get a blood pressure lowering effect, these patients are at higher risk of side effects, including hyperkalemia and other things. So we don't combine those agents anymore. So moving on now to the most challenging part of the talk, and that is management of patients with congestive heart failure and chronic kidney disease. So firstly, these two comorbidities often coexist. And this is just a slide showing this statistic in U.S. Medicare beneficiaries, that regardless of age, over 40% of people with congestive heart failure also have comorbid chronic kidney disease. So this is something that you can't get away with dealing with. And to highlight some of the challenges in management, I'm just going to present a patient of mine, Mr. GW, this is not his picture, who's a frail 76-year-old man who has a history of hypertension, coronary artery disease with an EF of 35%, New York Heart Class 2 symptoms, history of AAA repair, peripheral vascular disease surgery in both legs. He also had AFib, but I thought, slide's getting long. He's on ramipril 10 milligrams a day, spironolactone 25 milligrams a day, metoprolol 25 milligrams BID, furosemide 40 a day, and atorvastatin 40. And his baseline creatinine is running between 150 to 175 when he was initially referred to me, giving him a GFR of about 35, and has no proteinuria. ACR is less than 3. So this is a man who has current symptomatic heart failure. And so I just wanted to briefly review here in the slide that I know doesn't project all that well, what the evidence-based therapies are, which I know you're all very familiar with, and that is that patients with a history of symptomatic CHF, first-line agent should be to be on an ACE or an ARB and a beta blocker, which this patient is. And then for volume-overloaded patients, adding a loop diuretic. And then for patients who still have relatively preserved kidney function, GFR above 30, and no hyperkalemia, to add on an aldosterone antagonist. So this man is on all the therapies. And although we don't have randomized studies in CKD in particular, subgroup analyses of other trials, the general heart failure trials, looking at the CKD subgroup in those trials have shown benefit in terms of these therapies. And so, in as much as we can, we do make an effort to have CKD patients on these therapies as well. The thing with these patients is that they need closer monitoring. There's no question that there are increased risk of adverse effects, and most importantly for us on the kidney side, it's hyperkalemia and acute kidney injury when they're on these therapies. So the bottom line is these patients are high maintenance. They do require more frequent office visits for assessment of their treatment tolerability, their volume status, especially during periods of instability or when new treatments are instituted. How about lab monitoring of patients on these therapies? And of course, here we're mainly talking about ACE inhibitors, ARBs, loop diuretics, spironolactone. In general, it's good practice to check their kidney function at baseline, to check it again after 1 to 2 weeks of starting treatment, and that goes for basically anyone starting an ACE inhibitor or ARB, of course. I recommend that you also check it when you're up titrating treatment. Don't assume if they, tolerate 5 of ramipril, they're going to tolerate 10. During periods of instability, which not only means heart failure instability, but other instabilities, such as, other, acute infections and other things that might happen. And then periodically thereafter. And I know that's a bit vague, the periodically thereafter, but that will depend on the person's degree of CKD and their history of tolerability of these treatments. For this man with GFR, 25 to 30 range, he was initially getting blood work done every 2 to 3 months, basically. So these patients should feel like you have a close eye on them. Okay, so this patient over the initial 2 years of follow-up had a fairly stable cardiac status. His creatinine did slowly creep up to the 200 range, so GFR now dropping to about 27 mils per minute. He started to develop intermittent hyperkalemia. Potassiums would often range between 5.3 to 6.1. So hyperkalemia is something that you should really anticipate in chronic kidney disease patients on ACEs and ARBs. Okay, and he has a number of risk factors in addition to the fact that he's on 2 potassium-sparing agents that put him at risk of hyperkalemia. First of all, he's old. Second of all, he has symptomatic heart failure, and the risk of hyperkalemia increases the more symptomatic you are. And he has CKD. His GFR is in the 30 ml per minute range. So if you really want to give patients the benefits of these therapies, you might need to do do some preventative therapy, essentially, and that is give them some dietary advice up front to reduce their risk of hyperkalemia. And this is a slide highlighting a few particularly bad foods, but there are plenty of lists out there. And I'll just also say that, in the kidney clinics, this is what our dietitians often spend their time on, counseling about potassium restriction. So multidisciplinary care can help maintain these patients on medications that will help them. So what about when to stop an ACE inhibitor angiotensin receptor blocker? So hyperkalemia would be one of them. Here I've put off there's no real absolute cutoff, okay? Here I've said above 5.5, you might at least want to think about stopping it. And the truth of the matter is you might actually be able to continue it, or if you've stopped it, to restart it afterwards, if you can address some of the potential contributors to hyperkalemia. So dietary issues and other medications that they might be on that can contribute to hyperkalemia. So a couple of common ones would be, Septra, if someone happens to have a urinary tract infection, and NSAIDs, but hopefully your patients with CKD and heart failure are not on NSAIDs anyway. We also advise to stop ACEs or ARBs if creatinine rises greater than 30% from baseline, or eGFR falls by 25% from baseline within the first few weeks of treatment. In addition, if someone develops acute kidney injury when they're on one of these treatments, it's advisable to discontinue, because at that point your ACE inhibitor angiotensin receptor blocker might actually contribute to making them worse. And then when their acute illness resolves, you can consider reintroduction of therapy with follow-up again of their kidney functions after you reintroduce it. And just this is now the third plug for sick day advice. I must say I like Dr. White's sad man. The BC Renal Agency also has a handout that's available on the website for sick day management, which basically tells patients, if you have nausea, vomiting, you're unable to maintain your fluids, you need to discontinue medications that will increase your risk of acute kidney injury. So ACE, ARB, diuretics. And if you've stopped them for a couple of days and you're still sick, then you need to contact your care provider about what you need to do from there. So these handouts, I think, are very useful for patients, and hopefully in the long term help to prevent the risk of acute kidney injury, which we'll be hearing about a little bit later this morning. So what about people who just can't tolerate ACEs and ARBs? Well, the bottom line is not all patients tolerate ACEs and ARBs. And in the setting of heart failure, remember that there is actually a randomized trial from the 1980s that showed mortality benefit for hydralazine plus nitrate. So that is your sort of go-to if the ACE and ARB doesn't work out. Finally, here a word about aldosterone antagonists. Of course, spironolactone being the most common, but eplerenone is sometimes used as well. These people really have an increased risk of hyperkalemia if they have any, real chronic kidney disease. So it's recommended that you consider using a lower starting dose, so 12.5 milligrams daily. If someone already has a high or borderline high potassium, don't start it. Do something first to try to reduce their risk. For example, get them some dietary advice and see what that does to the potassium first. In general, these medications are considered to be contraindicated if the GFR is less than 30. That being said, some patients are able to tolerate it at lower GFRs, but that is a level where you should think twice about prescribing it in the first place. And again, just need to follow the potassium levels closely. So Mr. GW then develops acute decompensated heart failure. He has increasing shortness of breath, orthopnea, and edema over a 2-week period. He goes to ER. He didn't have an acute coronary syndrome, but he was in CHF. His labs showed worsening renal function, so creatinine now up to 270, and he's hyperkalemic at 5.6. So I just want to spend a couple of moments talking about acute decompensated heart failure. And its relevance in kidney disease is that these people are at high risk of acute kidney injury, a short-term worsening in their kidney function related to heart failure and its treatment, which can potentially not recover. So partly what we want to try to do is anticipate that this is a risk and try to prevent it. So ideally, you want to avoid the patient being hypotensive. You want to maintain a MAP of 60 or higher. Avoid nephrotoxins, and we've heard this already, but avoiding IV contrast for CT scans during these periods, avoiding NSAIDs, and interestingly, avoiding increasing intra-abdominal pressure may also help. So things like urinary retention and constipation can make these patients worse. What about diuretic dosing in this case? So in general, you should be using a loop diuretic. The most common one, of course, is furosemide that we use. In terms of the initial dose, you at least want the dose to be equal to and more likely higher than the dose that they're getting at home. And you're not going to give it to them orally. You would give them to them intravenously because in the state of congestion, the bowel wall may be edematous and their absorption of oral loop diuretics might be poor, and so they won't be effective. The frequency is often better to administer it twice a day to prevent rebound sodium retention because the half-life of furosemide is only about half a day. And once you choose a starting dose, you want to escalate it until symptom relief occurs, or if the renal function is getting worse, then you want to review the dose. And for the case of diuretic-resistant patients, adding a thiazide-like diuretic can help, for example, metolazone. And if you're getting to the point where your patient is requiring very high doses of diuretics and requiring this sort of add-on therapy, you may want to consider specialist referral. So what should you do with the ACE and ARB in acute decompensated heart failure? So ACEs and ARBs are medications that we have patients on for long-term benefit. Being on an ACE inhibitor and ARB for 2 or 3 days, on or off of it, is really not going to make a long-term difference. And the priority in acute decompensated heart failure really is to get them out of CHF. So decongestion with diuresis is the priority. And if you're aggressively diuresing someone, in those cases, ACEs and ARBs can actually contribute to worsening renal function. So in people who you feel are at higher risk of acute kidney injury, it is sensible to withhold the ACE or ARB. And examples of patients would include frail elderly patients and those with pre-existing kidney disease or already have acute kidney injury like this man did when he actually presented with his decompensated episode. So I've just sort of written some example orders here, not to forget about the cardiac and renal diets. You want him to be sodium and potassium restricted. If you were hyponatremic, you'd be very keen to restrict his fluid, although of course we know the cardiologists always fluid restrict all CHF patients. I think a sensible furosemide dose for him would be 60 IV twice a day, at least in the short term to get him out of his congestive phase. Stop the ramipril and consider replacing it with nitro patch and hydralazine. Stop his spironolactone, mainly because he's hyperkalemic, and follow his weights as your assessment of his diuretic effectiveness in addition to his symptoms, and also follow his lab tests daily during his hospitalization. And I just want to point out that people in this situation, this elderly patient with CKD that comes in with heart failure, these people really are at high risk of adverse outcomes in the short term. And the adverse outcomes that I'm talking about are end-stage kidney disease and death. So this here is a study that was recently published. It was based in Toronto, where they looked at these two things in people that had comorbid CHF and CKD. And in the first 3 years of follow-up, about 8% of patients actually got to end-stage kidney disease. And you can see the number of admissions for heart failure is shown there, where if you have 3 or more admissions for heart failure, your hazard for getting end-stage kidney disease is now 14 times above baseline. So this is a real flag that this person's in trouble. And also, very importantly, the mortality of these people is very high. So 17% of the cohort actually died within 3 years. So this is 25% of patients either getting to end-stage kidney disease or dying within 3 years. So given that these are high-risk patients, probably nearing the end of life in many cases, referral for specialist help is often a good idea, again, because we have access to a multidisciplinary team where we can sort of attack the various aspects of the person's care, because we have a nurse, a dietitian, a pharmacist, social worker. So not only can we assist with the medical management of a CKD and heart failure, but because these patients are at such high risk of end-stage kidney disease in many cases, we want to start talking to them about end-of-life care, end-stage kidney disease planning, because not all these patients are necessarily appropriate for dialysis, as we've heard in the earlier talks. And it takes time to educate people about, what does it look like to be nearing the end of your life and not have dialysis versus having dialysis. And it, I think, does a patient a disservice, really, when they're sort of referred at the last minute, because we're suddenly trying to do things in a very expedited fashion. Everyone feels pressured to make decisions, and that might be an example of a time where the person ends up on dialysis, where maybe that was really not the optimal route for the patient. So my last slide here is just to emphasize a few take-home points, and that is that remember that patients with CKD, are more likely to die of cardiovascular disease than they are to develop ESRD. The second thing is with respect to blood pressure control and targets in CKD. I think, remember that the CHEP guidelines are reasonable, but it's a moving target, and these things will likely change in the longer term. And finally, patients with heart failure and chronic kidney disease, this is a potentially hazardous combination. These patients are high maintenance in that they need a lot more close monitoring. And if patients are deteriorating with respect to their kidney function, that is probably someone you may want to refer for specialist care sooner rather than later. Thank you. Good thing it only cut out right at the end. So I'm not sure were we taking questions now? Okay, yeah.
We're going to take some questions now. We're going to take a 15-minute break shortly. Those were fantastic talks, and I want to thank our speakers. I think we're all privileged to be part of such great knowledge. I just want to stress and remind my primary care colleagues the added challenge we have is not just with medications that are evidence-based. The literature is quite clear about medication adherence, that in the chronic disease setting, we're lucky about 50% of people are taking their medications 2 years out. So and that's been well studied. So in these cohort of patients with multiple chronic diseases, what can we do as primary care teams and providers to improve that 50% compliance rate with evidence-based medicine? It's just food for thought. So I want to open up some questions now. Anybody, before we take our break, does anybody have anything they want to ask our specialists? If not, we can wait to the end. Oh, we have an online.
Yeah. I have a question probably for Nadia. Is there any advantage over pilrenone versus spironolactone?
Okay, so my own take on this is really this is a side effect issue. I don't think that there is an advantage with respect to hyperkalemia as a side effect of spironolactone versus a eplerenone. At least I'm not aware of anything. But spironolactone does have some nuisance side effects, particularly in men, where it can cause gynecomastia. And, if you've already got heart failure and chronic kidney disease, you don't need any more problems. So that may be someone, for example, where you may favor use of a eplerenone.
Any other questions from on-site or remote participants? All right, I'll ask the speakers that can just to stay around at the lunch break, at the coffee break, in case there are questions, and we'll try to repeat them as we start the second three speakers so that everyone hears what we chatted about. So thank you again to all the speakers.
15 minutes, please. Okay, guys?